I am Professor Hemantha Senanayake, the Chair Professor of Obstetrics and Gynaecology in the University of Colombo in Sri Lanka. Today, I am going to talk to you about an interesting innovation which has become an essential part of modern obstetrics. Balloon tamponade for postpartum hemorrhage has saved countless lives, and also it has saved the uteri for a lot of women who would have had to have a hysterectomy to prevent dying from postpartum hemorrhage. In this module, I am going to take you through the basics of a condom catheter and other methods of balloon tamponade for postpartum hemorrhage, and also I am going to give you a demonstration on how to do a condom catheter, which is the cheapest way of performing a balloon tamponade. Postpartum hemorrhage is a leading cause of maternal death, especially in the developing world, where it accounts for an annual mortality of approximately 150,000 women. It remains a serious complication of childbirth in both the developed and developing countries, and from about 2 to 5% of women who deliver will have a postpartum hemorrhage with a volume of over 1 liter within the first 24 hours. The commonest cause of a postpartum hemorrhage is an atonic uterus, where the uterus fails to retract properly after childbirth. Postpartum hemorrhage should be considered a preventable complication of childbirth. One of the main reasons for death due to postpartum hemorrhage is delay in diagnosing the hemorrhage, and therefore the rapid estimation of blood loss remains the key for early diagnosis. We strongly recommend that you complete the module on visual estimation of blood loss along with this module on balloon tamponade for postpartum hemorrhage. In a balloon tamponade, the balloon is inflated with either saline or water to exert pressure from within the uterus to stop bleeding. It can circumvent the need for a laparotomy and hysterectomy very effectively. The reported success rates for control and management of postpartum hemorrhage with uterine tamponade range between 70 and 100%, making it a very effective intervention in postpartum hemorrhage. There are many types of devices we could use for a balloon tamponade. Some of these have come from different fields of medicine and were developed, in fact, for other purposes. For example, the Sengstaken Blakemore tube and the Rushed hydrostatic catheter, these were developed for other purposes. We also now have devices like the Bakri balloon, which has been purpose-built for postpartum hemorrhage. The costs of these devices will differ widely. For example, the Bakri balloon on an average will cost about $250. However, the condom catheter that we are talking to you about today mostly can be done for as little as $2 per procedure. It was developed in Bangladesh by Asker and her team. It costs very little, like I told you short while ago, and it is very effective. However, I must advise you that for it to be effective, it has to be done correctly. We will now consider when to use a balloon tamponade with whatever device you are going to use. When other causes of bleeding other than atonic bleeding is excluded, then there is a clear case for using a balloon tamponade. It is essential that before we go to a surgical intervention that a balloon tamponade is used. Today we in fact talk about a tamponade test. That is, you go into a surgical intervention only when the tamponade test has failed. That is, in other words, despite one inserting a balloon tamponade, the bleeding continues, and that is an indication for a surgical intervention. In that way, the balloon tamponade can be used also as a test to see whether a conservative measure in relative terms could work before you proceed to a surgical intervention. Now we will look at when not to use it, the contraindications. When there is rapid arterial bleeding which would require exploration of the uterus or ligation or angiographic embolization, it should not be used. Cases where there is a clear indication for hysterectomy. In a congenital uterine anomaly where one would think that the balloon will not sit correctly inside the uterus, say for example due to a septum, then it will be of limited use. Uterine distorting pathology like a leiomyoma. However, personally I would advise that we first give the balloon tamponade a chance. Even in these kind of situations, it may well work. In a suspected uterine rupture, it is contraindicated for sure, and you would need to then proceed to a laparotomy. Obviously, where there is a purulent infection in the vagina, cervix of the uterus, it's contraindicated. If a person is allergic to the balloon material, it is contraindicated. Disseminated intravascular coagulation is very often quoted as a contraindication. However, we have used balloon tamponade in women with DIC, and the women have bled from everywhere else other than the uterus in these instances. So personally, again, I would advise that we try a balloon tamponade even in the presence of a disseminated intravascular coagulation, rather than trying to do a surgical procedure on a woman who is already having a tendency to bleed. Before I end the introduction to this, I would say in a woman who is having a postpartum hemorrhage, a balloon tamponade is the standard of care before embarking on a laparotomy or hysterectomy for postpartum hemorrhage. As I said before, this is what we consider as the tamponade test, where we insert the tamponade and first see whether the woman would respond and then proceed to the surgical procedure. Now let us look at what we require to do a condom catheter. Obviously, you're going to need the commercially available condoms, and most makes will be fine on that. You would need a catheter, a Foley catheter, and I would advise you to use at least a gauge 20 or 22 catheter. The reason for this is that these broader gauge catheters are firmer and it is easier for us to get it into the uterus. By itself, it can be pushed in. Otherwise, you would need the help of a sponge holding forceps to get it into the uterus. You would need some ordinary kind of sutures to tie the condom onto the catheter. It could be an old-fashioned silk or the more modern synthetic material. It doesn't matter so long as the material is strong. You would obviously need the saline. You would require to have about a liter, but in most of the instances the uterus will take only about 350 milliliters of saline at most. It is good to have them warmed because inserting cold fluids into the body will create hypothermia, and this could interfere with coagulation. You would need a giving set to fill the condom with saline. You would require sponge holding forceps. You would require 2 of them. You would require a Sims speculum, and very importantly, a vaginal pack. I would advise that when you're inserting the vaginal pack, to keep the balloon in, you would need to moisten it with warm saline. Many of the times when a condom catheter fails, it is because the person who has inserted it has not packed the vagina with a vaginal pack. That is an essential part of inserting a condom catheter. Now let us look at how to prepare a condom catheter. This is a procedure that could be done in the labor room, or you could move the patient to the theatre. We mustn't forget to reassure the mother and to explain to the mother the procedure in simple terms. You need to tell her that you're going to perform a procedure that will stop her bleeding. First of all, we would need to take the condom out of the packing and keep it on a sterile table. We would need to take the catheter out of the packing and then roll the condom over to cover about 6 centimeters of the catheter. We would then take the suture material out of its packing, because we want to keep this procedure as a sterile procedure, and we would need to tie the condom onto the catheter in such a way that it is watertight, but not tight, not too tight to obliterate the lumen of the catheter. I have now tied the condom onto the catheter, covering about 6 centimeters. It's been tied firmly. I can't move the condom up and down, and I will now connect it to the saline and see if the system is waterproof. So I would hold it in my hand and fill the catheter with saline. Can put in about 50 milliliters, and at the end of it, once I have filled the catheter, I will turn it upside down to ensure that it is watertight. Once you are satisfied that your system is watertight, you could then proceed to inserting the system into the uterus. If you would look carefully at this condom catheter, you would see I have placed 2 ligatures at the bottom of it. That was because the first one did not make it watertight. Because I was not satisfied with the watertightness of the system, I supplemented it with another ligature which made it watertight. Before inserting the catheter, you would need to empty the saline from the system. To do this, there are 2 methods. One is simply by disconnecting the giving set from the catheter from here, or else if you want to maintain the watertightness of it, you could simply leave the bottle at the bottom or on the floor and then open the tap of it, and as you will see here, it will empty gradually. At this point, you would need to make a judgment as to whether you want to get the catheter straight away in, or you have a few minutes to spare to get the system emptied. Once your system is ready for insertion, then we could proceed to insert it into the uterus. The mother should be in the lithotomy position, and we would need to clean and drape the mother's perineal area, and using a SIM speculum, I would proceed now to expose the cervix. Once it is exposed, I would use a sponge holder or a green armitage forceps and grab the anterior lip of the cervix. Once that is held in the sponge holder, I would take the condom catheter, hold it in another sponge holder and proceed to insert it into the uterus. As I had said previously in this video, if we had used a broader gauged catheter, a thicker one, to make this system, it would have been much easier to insert this into the uterus. Once it is inserted, it might be prudent to support it with a sponge holder just to make sure that it's not slipping out as you're filling it. Once you have inserted the system into the uterus, then we will proceed to filling the condom with saline. To do this, you would need to hold the saline bottle at a height of 1.5 meters from the level of the mother. I want to reiterate that the filling has to be done passively. You do not need to squeeze the saline into the system. As you can see, now the condom is getting filled with saline under passive pressure provided by the bottle. While this is happening, it is vitally important that you keep observing the cervix to see if you could see the balloon protruding out of it. Now, that is an important point in this procedure. When that point is reached, it indicates that the balloon might get expelled from the uterus at any point. At that point, we would need to close the tap of the giving set. Usually this point is reached when about 350 milliliters of saline has been filled into the balloon. This is a very important point in this procedure because that signifies the point where the balloon could slip out of the uterus. So it is very important at this point that you take a vaginal pack, moisten it with warm saline, and you pack the vagina tightly so that you're supporting the balloon inside the uterus and so that it will not get pushed out into the vagina. Time and again we have seen this procedure fail because people have failed to follow this step of the procedure. Sometimes you might need more than one vaginal pack to accomplish this. So once that is done, you come to the next phase of the procedure. While the balloon is being filled up, there is another observation that we should be doing. That is, we could observe the cervix and the blood coming out of the uterus to see whether that is stopping as the balloon is getting filled. That is indeed the usual scenario. As the balloon is getting filled up, you could notice that the bleeding is stopped. If there is continuing bleeding, that indicates that the condom tamponade might fail. So you need to be vigilant in that kind of situation. Or you could choose to abandon the procedure and proceed to a surgical measure straight away. Once you are satisfied that the vagina has been packed satisfactorily, you could proceed to removing the sim speculum that was exposing the vagina. And then we reach another important stage in this procedure. We would now, with the vaginal pack in place, open the tap of the giving set and allow the balloon to fill under passive pressure by holding the saline bottle at a height of 1.5 meters from the level of the mother. Once we are satisfied that there is no more filling, we would then close the giving set and proceed to removing the giving set from the catheter. So what you would need to do is to remove the giving set from the catheter and to securely tie this so that there is no leakage of saline. We would do that with one or maybe two ligatures, or maybe you could apply a pair of artery forceps and hold it there. In this instance, I have chosen to close off the catheter with one ligature, which is securely holding the catheter blocked in place. Now let us consider the observations that you have to do on a woman who has a condom catheter in place. It is important for us to realize and appreciate that once the condom catheter is in place and the vagina is tightly packed, if the woman continues to bleed from the uterus, there is no way that that blood is going to come out of the vagina. So we might have a situation potentially where the woman is bleeding from the uterus, but there is no vaginal bleeding. Therefore, it is very important that after we have inserted a condom catheter and packed the vagina, that we clearly mark the level of the fundus of the uterus on the abdominal wall of the mother. This is one of the main aspects that we would need to monitor in this woman. We have seen catastrophic bleeding taking place unnoticed because the blood was collecting in the uterus after a condom catheter was inserted. Secondly, we would need to have a careful chart of the pulse and the blood pressure and the level of consciousness of the mother. These women will almost invariably have a urinary catheter inserted. We would need to maintain an hourly urine output chart as well. Now we will consider how we should proceed to remove a condom catheter. In a woman where the condom catheter has stopped the bleeding and there has been recovery on the part of the mother, we should proceed to removing the catheter. Different countries and different units will use different policies about how to remove a condom catheter or a balloon tamponade. I will share with you the policy that we have been following in our unit. We would keep a condom catheter for a minimum of 12 hours. And when we have decided to remove it, what we would do first is to remove half the volume that has been inserted into the balloon. Once we have removed half the volume of saline that we had inserted into the condom, we would then observe the mother for a further 1 to 2 hours to ensure that there is no recurrence of bleeding. If the observations of the mother have been stable, we would then proceed to remove all of the saline that has been inserted into the balloon. So this will be after a minimum of 1 to 2 hours of observations, and we have not done anything with the packing that has been in the vagina. We will not remove that until we are very certain that we could remove the whole system. Once we have removed the saline completely from the system, we would continue to watch the mother for another 1 hour. Again, the packing in the vagina remains there where it is, and the catheter also remains where it is. The idea for this is very simple. If we have any evidence of recurrence of the bleeding, all we have to do is simply to refill the balloon. Once we have observed the mother for another 1 hour with all the saline removed from the system, then we could consider removing the packing and the catheter completely from the uterus. Even then, because this is a mother who has had a hemorrhage, we would need to observe her closely. And now to some useful tips. It is extremely important that you do not grasp the condom with the sponge holder or any other such device, especially when you are trying to insert it, because it will create a weakness at that point which will make it liable to rupture while you are filling it. Secondly, now there is good evidence after the woman trial that a woman who is bleeding postpartum requires to be given tranexamic acid 1 gram. By the time you insert the condom catheter, this really should have been given, but while you are inserting it, if it has not been done, this is something for you to consider. Some practitioners recommend the use of 2 condoms, one over the other for greater security, so that if one ruptures, the other one will keep the pressure on. It is very important for us to have our patient covered with intravenous broad-spectrum antibiotics. A good example for this would be cefuroxime and metronidazole. That concludes my presentation on how to insert a condom catheter. If you wanted to practice this in your facility, which we would strongly recommend that you do not need to go looking for dedicated models to practice it on. You could just as well use a plastic bottle or even a glass bottle instead of the uterine model that we have used here. I'd like to reiterate that the condom catheter has been a major innovation in modern obstetrics. It has saved countless lives. It can save the woman from a hysterectomy or a laparotomy, which in this situation of bleeding could by itself be life-threatening. We would now request you to proceed to the post-test of this module, and I hope you enjoy answering those questions. Thank you.